So, Treponema is a spiral-shaped organism, but it's gram-negative. All right, if you go to the giant microbe site, they actually do have a doll. Go figure. My daughter comes to my office one day, sees the huge box of giant microbes, and her favorite color is pink, as most little girls, right? So the syphilis doll is pink, and it's a little coil-shaped pink doll. So she's like, Mommy, Mommy, can I have this one? Sure. Can I bring it for show and tell? No, you may not bring it for show and tell. You'll get a. She didn't understand, but she still has the doll, so I couldn't bring it. Anyways, nice little coil-shaped bacteria. It does not gram stain very well, which is why when we talk about the diagnosis for syphilis, we're going to talk screening test, we're going to talk confirmatory test, etc. Species of medical importance, we are going to focus on Treponema pallidum, which is the causative agent of syphilis. And if you're a fan of Thursday night TVs, the Sif. All right. Distinguishing features, again, they're spiral-shaped. That's huge. You definitely have to know that. What's going to allow it to move? Remember, not flagella, but the axial filaments that give it motion. We can't culture it in the lab, so we have to revert it to serodiagnosis. And the last feature that you see here on the slide is that it's an obligate pathogen, but it's not an obligate intracellular. This basically means that we can't culture it. We can't culture it in the lab. Now, it's a sexually transmitted disease, but it can also be transmitted vertically. It can cross the placenta. And one of the things that is classic for syphilis is it's one of those classic chronic diseases. So one of the things you're going to have to be able to do for step one is distinguish, because this is a chronic infection a lot of the times, between primary, secondary, tertiary, latent syphilis. So the other bullet point here under pathogenesis is what I'm going to call again a money question for syphilis, which is that a lot of the times in latent syphilis we wind up with aortic aneurysms that are due to the organism because it causes endarteritis. So you get aortic aneurysms from syphilis in some of those later stages of the disease. Now I'm going to talk about the different stages of syphilis. We'll talk about primary, secondary, and go through the different stages. Again, very important for step one. You're going to have to be able to differentiate between the stages. Now, primary syphilis, again, you have a chancre. We talked about that with Haemophilus ducreyi, but it doesn't hurt. You may cry, but it doesn't hurt, okay? So it is a non-painful chancre, and this chancre will heal by itself in about a month or so, spontaneously. Without antibiotics, it will heal, but that doesn't mean you've gotten rid of the infection. To diagnose primary syphilis, you can do a scraping of the lesion and do dark field or fluorescent microscopy. But at this point, 50% of patients in primary syphilis are going to be negative by the screening test that we use to diagnose syphilis. Now, you get the chancre, you cry or you don't, it heals, you get into secondary syphilis. Secondary syphilis is characterized by a rash. It is a maculopapular rash, sometimes described as copper-colored, and it is on the palms and soles. And it's infectious from the palms and soles. That rash on the hands, everywhere, is infectious. Might make you think twice about shaking hands with people that you don't know. Now, aside from the rash, you also have hair loss, patchy alopecia. It can be in the head or the scalp. In men, you'll also notice it very commonly in the beard, okay, and the facial hair. But it can also be in the scalp as well. So we have a copper-colored rash, we have patchy hair loss, and we have something called condylomata lata. This looks very similar to HPV, genital infection. So really, in the genital region now, you have these fleshy wart-like lesions that are also extremely contagious, teeming with live spirochetes. In secondary syphilis, you're typically positive by both mechanisms that we use to test for syphilis, the nonspecific and the specific tests. Latent syphilis, there may not be any overt clinical signs. You would be positive by serology, but if you're not really showing any symptoms per se, then there's really, it would be unusual that they would catch you at that specific stage of the illness. Now let's go into tertiary syphilis. Okay, in tertiary syphilis, this is when we think aortic aneurysm. This is when we think CNS lesions. Okay, and tertiary syphilis, we're talking major chronic. There are a lot of famous people in history that actually had chronic and tertiary syphilis. You can Google that. You can Google famous people with syphilis, and you'll be surprised with the list that comes up. Government officials, lots of artists, poets, etc. come up. Clinically, with tertiary syphilis, again, the aortitis or aortic aneurysm, and what we call GUMAs. A GUMA is basically a granulomatous lesion that's in the CNS. So you're going to see this on a scan. You'll see lots of inflammation in the CNS, and that's considered a GUMA. Now, what's the diagnosis in tertiary syphilis? As far as the serology, we have to go with a specific test because now we may have lost the reaction that gives us the nonspecific antibody tests. And congenital syphilis, where it can cross the placenta. Usually, you'll see in infants of IV drug users, for example. Again, we have a huge range of things that can happen, from asymptomatic to stillbirth, and anywhere in between. I'm going to point you out to a few things that seem to be more common with syphilis than with some of the other diseases. Notably, you have eighth nerve damage, okay? That's very common with congenital syphilis. Notched teeth. So sometimes they're called Hutchinson teeth, and you'll notice the teeth on the children will actually have very kind of deep ridges in them or notches. Now, the other thing that you can see is tabes dorsalis again, and that's not necessarily listed there, but that's also very common as far as congenital syphilis. The other thing, when we say asymptomatic, we mean that you can have an infant born and all of a sudden they develop kind of rhinitis. And the rhinitis, though, is extremely infectious for syphilis. So the mucous membranes are going to be teeming with infectious treponemes. There can also be a maculopapular rash in congenital syphilis. Now, how are we going to diagnose this? Okay, serology, a little bit tricky here. It should revert to negative within 3 months of birth if uninfected. Okay, so the serology is a little bit interesting as far as the diagnosis for congenital syphilis. Now, speaking of diagnosis, we've got the two tests. I said this was extremely important. You have a screening test and you have a confirmatory test. The screening test is a non-treponemal antibody test. So what we're doing is we are screening patients to see if they're reactive to this non-treponemal antibody test. And what we do is, as a source of antigen for this test, we use cow heart, for example, and you get a cross-reactivity between the antibodies for syphilis and the antigens that you find in these mitochondrial membranes. Now, some of these screening tests, VDRL, RPR, for example, VDRL, for example, stands for Venereal Disease Research Lab. So most of these abbreviations don't mean anything except for where the test was actually invented or, patented. So that's why all the abbreviations. But all of those are basically speaking to the screening test for syphilis. And again, as we said, it's sensitive in primary except for very early on, and it's good in secondary, and then it starts to decline. You're always going to have to confirm it with the FTA-ABS. And the FTA-ABS is your specific test. It's your confirmatory test for syphilis. So you screen with the nonspecific test. Now you confirm with a fluorescent antibody test. There are two tests that are used, but the FTA-ABS is the most widely used. The microhemagglutination is less commonly used. Treatment for Treponema pallidum is, believe it or not, still penicillin, but it's a long-acting form of penicillin called benzathine penicillin. One of the things you have to watch out for during treatment of a lot of the spirochetes, and we'll talk about it here with syphilis, is this Jarisch-Herxheimer reaction, where you start to treat and within 24 hours your patient goes into shock. And what's happening here is as you're treating, you're lysing these bacteria. Remember, this is a gram-negative organism, and you start to get toxemic, really, from the LPS. So that's the Jarisch-Herxheimer reaction. It's very, very common in the treatment of the spirochete diseases. As far as prevention, this is a nightmare. Prevention for syphilis, you have to go back to all the contacts, if you can find them, give them benzathine penicillin as far as prevention, because, again, there is no vaccine available for treponema.